My topic is shoulder complex. I, Dr. Payal Jain, Assistant Professor of Index Department of Physiotherapy and Paramedical Sciences. The shoulder complex, composed of the clavicle, scapula and humerus, is an intricately designed combination of three joints linking the upper extremity to the thorax. The articular structures of the shoulder complex are designed primarily for mobility, allowing us to move and position the hand through a wide range of space. The glenohumeral joint linking the humerus and scapula has greater mobility than any other joint in the body. Although the components of shoulder complex constitute half of the mass of the entire upper limb, the components are connected to the axial skeleton by a single joint, the sternoclavicular joint. As a result, muscle forces serve as a primary mechanism of securing the shoulder girdle to the thorax and providing a stable base of support for upper extremity movements. The contradictory requirement on the shoulder complex for both mobility and stability are met through active forces or dynamic stabilization, a concept for which the shoulder complex is considered a classic example. In essence, dynamic stability exists when a moving segment or set of segments is limited very little by passive forces such as articular surface, configuration, capsule or ligaments, and instead relies heavily on active force or dynamic muscular control. Dynamic stabilization results in a wide range of mobility for the complex and provide adequate stability when the complex is functioning normally. However, the competing mobility and stability demand on the shoulder girdle and intricately structural and functional design result in the shoulder complex being highly susceptible to dysfunction and instability. Components of shoulder complex. The osseous segment of the scapula of the shoulder complex are clavicle, scapula and humerus. These three segments are joined by the interdependent linkage. The sternoclavicular joint are by three interdependent linkage. The sternoclavicular joint SC, the acromioclavicular joint and glenohumeral joint GH. The articulation between scapula and thorax is often described as the scapulothoracic ST joint, although it does not have the characteristics of a fibrous, cartilaginous or synovial union. Instead, scapular motion on the thorax is directly a function of sternoclavicular, acromioclavicular or combined sternoclavicular and acromioclavicular joint motion. The scapulothoracic joint is frequently described in literature as a functional joint. The joint that compose the shoulder complex in combination with trunk motion can contribute as much as 180 degree of elevation to the upper extremity. Elevation of upper extremity refers to the combination of scapula, clavicular and humeral motion that occurs when the arm is raised either forward or to the side. Motion of the scapula on the thorax normally contribute about 1/3 of the total motion necessarily for elevation of the arm through the linked SC and AC joint motions, whereas the GH joint contributes about 2/3 of the total motion. Sternoclavicular joint, SC joint. The SC joint serves as the only structural attachment of clavicle, scapula and upper extremity to the axial skeleton. Movement of the clavicle at the SC joint, sternoclavicular joint, is inevitably produce movement to the scapula under conditions of normal function. because the scapula is attached to the lateral end of the clavicle. Similarly, any motions of the scapula must result in motion at the SC sternoclavicular joint. The sternoclavicular joint is a plain synovial joint with 3 degrees of freedom: elevation, depression, protraction, retraction, and axial rotation. This joint has a synovial capsule, a joint disc, and 3 major ligaments, that is costoclavicular ligament, interclavicular ligament, and posterior sternoclavicular ligament. This is all about sternoclavicular joint. In this, articular discs are seen: fibrocartilaginous interclavicular ligament, anterior sternoclavicular ligament, costoclavicular ligament, first costal cartilage, second costal cartilage, second sternocostal joint, double synovial, fibrocartilage, intercarticular ligament. Now, sternoclavicular articulating surfaces. The sternoclavicular articulation consists of 2 saddle-shaped surfaces, one at the sternal or medial end of the clavicle and one at the notch formed by the manubrium of the sternum and first costal cartilage. The sternal end of the clavicle and the manubrium are incongruent, that is, there is little contact between their articular surface. The superior portion of the medial clavicle does not contact the manubrium at all. Instead, it serves as the attachment for SC sternoclavicular joint, disc, and interclavicular ligament. Now, sternoclavicular disc. The sternoclavicular joint has a fibrous joint disc or meniscus that increase congruence between joint surface. The upper portion of the SC sternoclavicular disc is attached to the posterior superior clavicle. The lower portion is attached to the manubrium and first costal cartilage as well as to the anterior and posterior aspect of the fibrous capsule. The disc diagonally transects the SC sternoclavicular joint space and divides the joint into 2 separate cavities. Given its attachments, the disc acts like a hinge or pivot joint during clavicle motion. In elevation and depression of the clavicle, the medial end of the clavicle rolls and slides on the relative stationary disc, with the upper attachment of the disc serving as a pivot point. In protraction, retraction of the clavicle, the sternoclavicular disc and medial clavicle roll and slide together on the manubrial facet, with the lower attachment of the disc serving as a pivot point. The disc, therefore, is considered part of the manubrium in elevation, depression, and part of the clavicle in protraction, retraction. As the disc switches its participation from one articular segment to the other during clavicular motions, mobility between the segment is maintained and stability is enhanced. The disc serves an important stability function by increasing joint congruence and absorbing forces that may be transmitted along the clavicle from its lateral end. In figure, it can be seen that the unique diagonal attachment of the SC disc will check medial movement of the clavicle that might otherwise cause the large medial articular surface of the clavicle. To override the shallow manubrial facet, the disc also has substantial contact with the medial clavicle permitting the disc to dissipate the medially directed forces that would otherwise cause high pressure at the small manubrium facet. Now, sternoclavicular joint, capsule and ligaments. The sternoclavicular joint is surrounded by a fairly strong fibrous capsule but must depend on 3 ligaments for the majority of its support. These are sternoclavicular ligament and costoclavicular ligament. First, sternoclavicular ligament. The anterior and posterior sternoclavicular ligament reinforce the capsule and function primarily to check anterior and posterior translatory movement of the medial end of the clavicle. The costoclavicular ligament is a very strong ligament found between the clavicle and the first rib. The costoclavicular ligament has 2 segments or lamina. The anterior lamina has fibers directed laterally from the first rib to the clavicle, whereas the fibers of the posterior lamina are directed medially from the rib to the clavicle. Both segments check elevation of the lateral end of the clavicle. The costoclavicular ligament is also positioned to counter the superiorly directed force applied to the clavicle by the sternocleidomastoid and sternohyoid muscle. The medial directed fibers of the posterior lamina will resist medial movement of the clavicle, absorbing some of the forces that would otherwise be imposed on the SC disc. Third one, the interclavicular ligament. The interclavicular ligament resists excessively depression of the distal clavicle and superior glide to the medial end of the clavicle. The limitation to clavicular depression is critical to protecting structures such as the brachial plexus and subclavian artery that pass under the clavicle and over the first rib. In fact, when the clavicle is depressed and the interclavicular ligament and superior capsule are taut, the tension in the interclavicular ligament can support the weight of the upper extremity. The sternoclavicular motion. The 3 rotatory degree of freedom as at the SC joint are most commonly described: the elevation, depression, protraction, retraction. The anterior posterior rotation of the clavicle, the motion of elevation, depression, protraction and retraction should be visualized by referencing movement of the lateral end of clavicle. Clavicular anterior posterior rotation are long axis rolling motion of the entire clavicle. This is the lateral translation, superior translation, inferior translation. This is elevation and this is depression. Now, 3 degree of translatory motion at the SC joint can also occur, although they are very small in magnitude. Translations of the medial clavicle on the manubrium are usually defined as occurring in anterior posterior, medial lateral and superior inferior directions. Elevation and depression of clavicle. The motion of elevation and depression occur between a convex clavicular surface and a concave surface formed by the manubrium and the first costal cartilage. With elevation, the lateral clavicle rotate upward, and the depression, the lateral clavicle rotate downward. The cephalocaudal shape of the articular surface and the location of the axis indicate that the convex surface of clavicle must slide inferiorly on the concave manubrium and first costal cartilage in a direction opposite to movement of the lateral end of the clavicle. Now protraction and retraction of clavicle. With protraction, the lateral clavicle rotate anteriorly, and with retraction, the lateral clavicle rotate posteriorly. During protraction, the medial clavicle is expected to slide anteriorly on the manubrium and first costal cartilage. There is about 15 to 20 degree protraction and 20 to 30 degree of retraction of the clavicle available. Anterior and posterior rotation of clavicle. Anterior and posterior rotation of clavicle occur as a spin between the saddle-shaped surface of the medial clavicle and manubriocostal facet. Unlike many joints that can rotate in either directions from resting position of the joint, the clavicle rotate posteriorly from neutral, bringing the inferior surface of clavicle to face anteriorly. This has also been referred to as backward or upward rotation rather than posterior rotation. From its fully rotated position, the clavicle can rotate anteriorly again to return to neutral. Available anterior rotation past neutral is very limited, generally described as less than 10 degrees. The range available clavicular posterior rotation is cited as much as 50 degrees. Now, sternoclavicular stress tolerance. The bony segment of SC joint, its capsulo-ligamentous structure and SC disc combine to produce a joint that meets its dual function of mobility and stability. Well, the SC joint serves its purpose of joining the upper limb to the axial skeleton, contributing to upper limb mobility and withstand imposed stress. Although the SC joint is considered incongruent, the joint does not undergo the degree of degenerative changes common to the other joint of the shoulder complex. Strong force dissipating structure such as the sternoclavicular disc. Dislocation of SC joint represent only 1 degree of joint dislocation in the body. Now, our next joint is acromioclavicular joint. The acromioclavicular joint attach the scapula to the clavicle. It is generally described as the plain synovial joint with 3 rotational and 3 translational degrees of freedom. It has a joint capsule and 2 major ligaments. A joint disc may or may not be present. The primary function of the AC joint is to allow the scapula additional range of rotation on thorax and allow for adjustment of the scapula, internal and external, outside the initial plane of the scapula in order to follow the changing shape of the thorax as arm movement occurs. In addition, the joint allows transmission of forces from the upper extremity to the clavicle. The acromioclavicular articulating surfaces. The acromioclavicular joint consists of articulation between the lateral end of the clavicle and a small facet on the acromion of the scapula. The articular facet considered to be incongruent vary in incongruation. They may be flat, reciprocally concave, convex, or reversed. The inclination of the articulating surface varies from individual to individual. Now, acromioclavicular joint disc. The disc of the acromioclavicular joint is variable in size between individual at various ages, within an individual and between sides of the same individual through 2 years of age. The joint is actually a fibrocartilaginous union with use of the upper extremity, a joint space developed at each articulating surface that may leave a masticoid fibrous remnant within the joint. The capsules and ligament of acromio-clavicular joint are: the capsule of the AC joint is weak and cannot maintain integrity of the joint. Without reinforcement of the superior and inferior acromio-clavicular and coraco-clavicular ligament. The superior acromio-clavicular ligament assists the capsule in opposing articular surface and the controlling AP joint stability. The fibers of the superior AC ligament are reinforced by aponeurotic fiber of trapezius and deltoid muscle, which make the superior joint support. The coraco-clavicular ligament, the clavicle and the scapula, and provide much of the joint stability. This ligament is divided into a lateral portion of trapezoid ligament and the medial portion of coronoid ligament. The trapezoid ligament is quadrilateral in shape and is nearly horizontal in orientation. The coronoid ligament, medially and slightly posterior to the trapezoid, is more triangular and vertical oriented. The two portions are separated by adipose tissue and a large bursa. Both these ligaments attach to the undersurface of the clavicle. The conoid portion of the coraco-clavicular ligament provide the primary resist of the AC joint in the superior and inferior directions, whereas the trapezoid portion provide the majority of resistance to posterior translatory portion applied to the distal clavicle. In addition, both portions of the coraco-clavicular ligament limit upward rotation of the scapula at the AC joint when medially directed forces on the humerus, medially displacement of the scapular acromio-clavicular on the clavicle is prevented by tension, and the strength of the coraco-clavicular ligament transfer the force to the clavicle and then on the very strong SC joint. The acromio-clavicular motions. The articular facets of the AC joint are small, effort-limited motion and have a wide range of individual differences. The primarily rotatory motions that take place at the AC joint are internal-external rotation, anterior-posterior tipping and tilting, and upward-downward rotations. Internal and external rotation. Internal and external rotation at the AC joint can best be visualized bringing the glenoid fossa to the scapula anterior-medially and posterior-laterally respectively. These motions occur to maintain contact of scapula with the horizontal curvature of the thorax as the clavicle protract and retract, sliding the scapula around the thorax in the scapular protraction and retraction. Dempster provided the range of 30 of combined internal-external range of motion, AC joint separated from the thorax. Now anterior-posterior tipping. The second AC motion is anterior-posterior tipping or tilting of the scapula in relation to the clavicle. Anterior tipping will result in acromion tipping forward and the inferior angle tipping backward. Posterior tipping will rotate the acromion backward and inferior angle forward. Scapular tipping, like internal-external rotation of scapula, occur to maintain the contact of scapula with the contour of the rib cage and orient the glenoid fossa. Elevation of scapula on the thorax, such as occur as a shoulder shrug, can result in anterior tipping. The magnitude of anterior-posterior tipping during in vivo arm, elevation has been quantified as approximately 30 degrees, although up to 40 degrees. Now, upward and downward rotation. The third AC joint motion is upward downward rotation of the scapula in relation to clavicle. Upward rotation tilt the glenoid fossa upward and downward rotation in the opposite motion. The amount of available passive motion into upward downward rotation, specifically at the AC joint, is limited by attachment of the corticoclavicular ligament. However, Dempster described 30 degree of available passive range of motion in upward downward rotation. This is the scapula, upward rotation and downward rotation. This is the axis, medial lateral translations. Now, acromioclavicular stress tolerance. The AC joint is extremely susceptible to both trauma and degenerative changes. This is likely to be due to its small and incongruent surface that result in large force per unit area. Degenerative changes is common from the second decade on, with the joint space itself commonly narrow by the sixth decade. Now, third joint, scapulothoracic joint. The scapulothoracic joint is formed by the articulation of the scapula with the thorax. It is not a true anatomic joint because it has none of the usual joint characteristics. In fact, the articulation of the scapula with the thorax depend on the integrity of the anatomic AC and SC joint. The SC and AC joint are interdependent with the ST joint because the scapula is attached by its acromion process to the lateral end of the clavicle through the AC joint. The clavicle in turn is attached to the axial skeleton at the manubrium of the sternum through the SC joint. Any movement of the scapula on the thorax must result in movement at either the AC joint, the SC joint or both. That is, the functional ST joint is part of true closed chain with the AC and SC joint and the thorax. Normally, the scapula rests at a position on the posterior thorax approximately 2 inches from the midline between 2nd through 7th rib. The scapula also is internally rotated 30 to 45 degrees from the coronal plane. It's tipped anteriorly approximately 10 to 20 degrees from vertical and upward rotated 10 to 20 degrees from vertical. Now, resting position of a scapula. Motion of the scapula, upward and downward motion. Upward rotation of the scapula on the thorax is the principal motion of the scapula observed during active elevation of the arm and play a significant role in increasing the range of elevation of the arm. Overhead approximately 60 of upward rotation of the scapula on the thorax is typically available. Elevation depression. Scapular elevation and depression can be isolated by shrugging the shoulder up and depressing the shoulder downward. Elevation and depression of the scapula on thorax are commonly described as translatory motion, in which scapula move upward and downward along the rib cage from resting motion. Scapular elevation, however, occur through elevation of the clavicle at the SC joint and require subtle attachments and anterior posterior tipping and internal external rotation at the AC joint to maintain the scapula in contact with thorax. Next, protraction and retraction of a scapula on thorax are often described as translatory motion of a scapula away or towards the vertebral column. However, if protraction of the ST joint occurred as a pure translatory movement, the scapula would move directly away from the vertebral column and the glenoid fossa would face laterally. Only the vertebral border of a scapula would remain in contact with the rib cage. In reality, full scapular protraction result in glenoid fossa facing anteriorly with the full scapula in contact with the rib cage. Now, internal and external rotation. The scapular motion of internal and external rotation are normally not overtly identically or physically observation, but are critically to its movement along the curved rib cage. Internal external rotation of a scapula on thorax should normally accompany protraction-retraction of the clavicle at the SC joint. Internal rotation of a scapula on thorax that is isolated, the AC joint result in prominence of the vertebral border of the scapula as a result of loss of contact with the thorax. This is often referred to clinically as scapular winging or winging of a scapula. Excessive internal rotation may indicative of pathology or poor neuromuscular control of the ST muscles. Now, anterior posterior tipping. As it is a true for internal external rotation, anterior posterior tipping is normally not overtly obvious on clinical observation and yet is critically to maintaining contact of the scapula against the curvature of the rib cage. Anterior posterior tipping of the scapula on thorax occur at the AC joint and normally will accompany anterior posterior rotation of the clavicle at the SC joint. Anterior tipping that is isolated or occur excessively at the AC joint will result in prominence of the inferior angle of the scapula. Now, stability. Stability of a scapula on thorax is provided by the structure that maintain integrity of the linked AC and AC joint. The muscles that attach to both the thorax and the scapula maintain contact between these surfaces while producing the movement of the scapula. In addition, stabilization is provided through the ST musculature by pulling or compressing the scapula to the thorax. Now, our next joint is glenohumeral joint, that is GH joint. The GH joint is a ball and socket synovial joint with 3 translational and 3 rotational degree of freedom. It is a capsule of several associated ligament and bursa. The articulation is composed of large head of the humerus and the smaller glenoid fossa. Because the glenoid fossa of scapula is proximal segment of GH joint. Any motion of a scapula may influence GH joint function. The GH joint has sacrificed articular congruency to serve the mobility need of the hand and the subsequently susceptible to degenerative changes, instability and dearrangements. Now, glenohumeral articulating surfaces. The glenoid fossa of the scapula serve as the proximal articular surface, or the glenoid fossa may be tilted slightly upward or downward when the arm is at side, although representations most commonly show a slight upward tilt. The fossa also does not always lie in a plane perpendicular to the plane of the scapula. It may be anteverted or retroverted up to 10 degree with 6 to 7 degree of retroversion. Most typical with anteversion, the glenoid fossa faces slightly anterior in relation to the plane or body of scapula. With retroversion slightly posterior, the curvature of surface of glenoid fossa is greater in length than in width, with substantial variability between subjects. The humerus is the distal segment of GH joint. The humeral head has an articular surface that is larger than that of the proximal glenoid articular surface, forming 1/3 of the half of this sphere. As the general rule, the head faces medially, superiorly and posteriorly with regard to the shaft of the humerus and the humeral condyle. An axis through the humeral head, the neck in relation to the longitudinal axis through the shaft of the humerus forms an angle of 130 to 150 degree. This is commonly known as angle of inclination of humerus. This is the angle that is 130 to 150 degree. Now, glenohumeral articulating surfaces. In transverse plane, the axis through the humeral head and neck in relation to the axis through the humeral condyle form an angle that varies far more than other parameters, but is usually described as approximately 30 degree posteriorly. This angle is known as angle of torsion. The normal posterior position of the humeral head with regard to the humeral condyle may be termed posterior torsion, retrotorsion and retroversion of humerus. Because of the internal rotated resting position of the scapula on thorax, retroversion of the humeral head increases congruence of the GH joint by turning the humeral head backward and glenoid fossa of the scapula. Reduced retroversion. The result in a more anterior position of the humeral head on the glenoid surface, when the arm is in an anatomical neutral position. The humeral anteversion can result in an increased range of medial rotation of the humerus and reduced range of external rotation that places the humeral head at risk for anterior subluxation at the end range. Increased retroversion result in a more posterior position of the humeral head on the glenoid surface. When the arm is in an anatomical neutral position, humeral retroversion can result in increased range of external rotation of the humerus and reduced range of medial rotation. The humeral head at a risk of posterior subluxation at the end range. Now, glenoid labrum. When the arm hangs dependently at the side, the two articular surfaces of glenoid joint have little contact. The majority of the time, the inferior surface of the humeral head rests on only a small inferior portion of the fossa. The total available articular surface of the glenoid fossa is enhanced by an accessory structure, the glenoid labrum. The structure surrounds and is attached to the periphery of the glenoid fossa, enhancing the depth of the curvature of the fossa by approximately 50%. The labrum superiorly is loosely attached, whereas the inferior portion is firmly attached and relatively immobile. The glenoid labrum also serves as the attachment site for the glenohumeral ligament and the tendon of long head of biceps brachii. This is the diagram of glenoid fossa. And this is the glenoid fossa. This is the superior glenohumeral ligament, biceps tendon, superior spinatus tendon, subacromial bursa, infraspinatus tendon, glenoid labrum, teres minor, posterior bend, axillary pouch, anterior bend, subscapularis, and middle GH ligament. This is all about the glenoid labrum. Now, next is capsular ligaments of glenohumeral joint. The GH joint is surrounded by large loose capsule that is taut superiorly and slack anteriorly and inferiorly in the resting position. The capsular surface area is twice that the humeral head. More than 2.5 cm of distraction of the head from the glenoid fossa is allowed in a loose pegged position. The relatively laxity of the GH capsule is necessary for the large excrusion of joint surface, but provide little stability without the reinforcement of ligament and muscles. When the humerus is abducted, the laterally rotated on glenoid fossa, the capsule twists on itself and tighten, making abduction and lateral rotation the closed pegged position of the GH joint. This is the diagram in which inferior GH capsule, supraspinatus, lateral clavicle, acromion, subacromion bursa, and that is the deltoid muscle. When the arm is at rest, at the side, superior capsule is taut, whereas inferior capsule is slack. So this is all about the glenohumeral capsule and ligaments. The capsule is reinforced by the superior, middle and inferior GH ligament as well as by the coracohumeral ligament. However, a thin area of capsule between the superior and middle GH ligament is a particular point of weakness in the capsule, although the capsule is reinforced anteriorly by the subscapularis tendon. The foramen of Wittebelt is a common site of exclusion of humeral head with anterior dislocation of joint. So this is the diagram in which that is all the structures are present here. The three GH ligaments, superior, middle and inferior, vary considerably in size, extent and may change with age. Externally, the superior GH ligament passes from superior glenoid labrum to the upper neck of the humerus. The middle GH ligament runs obliquely from the superior anterior labrum to the anterior aspect of the proximal humerus. This ligament blends with the anterior capsule but has also been found absent in up to 30% of subjects. The inferior GH ligament has been described as having at least 3 portions and thus has been termed as inferior glenohumeral ligament complex. The 3 components of the complex are anterior and posterior band and the axillary pouch in between. The capsule is reinforced by superior, middle and inferior GH ligament as well as by coracohumeral ligament. However, a thin area of capsule between superior and the middle glenohumeral ligament is a particular point of weakness in the capsule, although the capsule is reinforced anteriorly by subscapularis tendon. The foramen of Wittebelt is a common site of extrusion of the humeral head with anterior dislocation of the joint. Now, function of glenohumeral ligament. The superior GH ligament contribute most to anterior and inferior stability by limiting anterior and inferior translation of the humeral head where the arm is at side, 0-degree abduction. The middle GH ligament contribute primarily to anterior stability by limiting anterior humeral translation with the arm at the side and up to 45-degree of abduction. With abduction beyond 45 degree with combined abduction and rotation, the ligament capsule plays a major role of stabilization. With abduction and axillary slack is taken up. The inferior humeral head translations with subsequent humeral external rotation from abducted position. With humeral abduction, the medial rotation is posterior band of the fans out the posterior stability of resistance to the posterior humeral translation. Now coracohumeral ligament. The coracohumeral ligament originates from the base of the coracoid process and may be defined as having two bands. The first insert into the edge of the supraspinatus greater tubercle where it joins the superior GH ligament. The other band insert into the subscapularis and lesser tubercle. The two band from the tunnel through which the tendon of the long head of the biceps brachii passes. It appears to be most important in limiting inferior translation of humeral head in the dependent arm. However, there is some indication that may also assist in preventing superior translation, especially when dynamic stabilizing force of the rotator cuff muscle is impaired. In addition, the coracohumeral ligament is usually reported as resting humeral external rotation with the arm adducted. Bursa. Several bursa are associated with the shoulder complex in general. With the GH joint specifically, the presence of bursa are indicative of the potential for frictional forces between structure. Although all bursa contribute to function, the most important are the subacromial and subdeltoid bursa. The bursa separate the supraspinatus tendon and biceps of the humerus from acromion, coracoid process, coracoacromial ligament and deltoid muscle. The bursa may be separate but are commonly continuous with each other. Collectively, the two are known as subacromial bursa. The subacromial bursa permit smooth gliding between humerus and supraspinatus tendon and surrounding structures. Interruptions or failure of the gliding mechanism is a common cause of pain and limitation of GH motion, although it rarely occurs as a primary problem. Now, glenohumeral motion. The GH joint is usually described as having three rotational degrees of freedom: flexion, extension, abduction, adduction, and medial and lateral rotation. Flexion and extension occur about the coronal axis passing through center of the humeral head. The GH joint is often considered to have 120 degrees of flexion and about 50 degrees of extension. Medial and lateral rotation occur about a long axis parallel to the shaft of the humerus and passing through the center of the humeral head. The range of medial lateral rotation of the humerus varies with position with the arm at the side. Medial and lateral rotation may be limited to as little as 60 degrees of combined motion. Abducting the humerus to 90 degrees of freeze the arc of rotation with GH values reported 120 degrees. The restricted arc of medial lateral rotation when the arm is outside may be related to different alignments of the greater lesser tubercle, which create mechanical block. Abduction-adduction of GH joint occur around the AP axis passing through the humeral head center. The maximum range of abduction at the GH joint is the topic of much disagreement. There is a general consequences, however, the range of abduction of the humerus in the frontal plane. The range of motion for abducting the GH joint, if impact for the greater tubercle is avoided, are reported to be anywhere from 90 to 120 degrees. Full range of motion of GH joint is to reasonable degree a function of the interarticular movement of the incongruent articular surface. The convex humeral head is substantially large surface and may have a different radius of curvature than the shallow concave fossa. Given incongruence, rotation of the joint around the three axes do not occur as pure spin but have changing center of rotation and shifting contact pattern within the joint. However, elevation of the humerus occurs at the articular surface of the humeral head slide inferiorly and in direction opposite to the movement of the shaft of the humerus, failure of the humeral articular surface to slide downwardly. The abduction of the humerus would cause superiorly rolling of the humeral head surface of the fossa. The large humeral head would soon run out glenoid surface and the head of the humerus would impinge upon the overhanging coracoacromial arch. If it has should articular surface of the head of the humerus slide inferiorly while head rolls up the fossa. Full range of motion can be achieved. Now, static stabilization of glenohumeral joint independent arm. Given the incongruence of the GH articular surface, the bony surface alone cannot maintain joint contact in between dependent position. As the humeral head rests on the fossa, gravity acts on the humerus parallel to the shaft in a downward direction. This appears to require a vertical upward pull, such as vertical force could be supplied by muscles such as deltoid supraspinatus and long head of the biceps brachii and triceps brachii. The line of gravity acting on the upper extremity create downward force on the humerus given the magnitude of passive tension in the structure of the rotation interval capsule that are taught when the arm is at left side. Resultant pull of both the LOG line of gravity and the rotator interval capsule create a line of force that compresses the humeral head into the lower portion of glenoid fossa, where the humeral head commonly sits when the arm is at side. In addition to the passive tension in the rotator interval capsule, two other mechanisms help provide static stability of the dependent arm. In healthy GH joint, the capsule has an all-right seal which produces negative interarticular pressure. This pressure creates a relative vacuum that resists inferior humeral translation caused by force of gravity, loss of interarticular pressure produced by venting the capsule or tear the glenoid labrum, result in a large increase in inferior humeral translation. It has also been demonstrated that degree of glenoid inclination influences the stability of GH joint. With the arm dependent position, there is a slight upward tilt of the glenoid fossa. Now, dynamic stabilization. It is generally accepted that the glenoid muscle is prime mover for GH abduction. The anterior deltoid is also considered the prime mover in GH flexion. The action lines of the three segments of the deltoid acting together coincide with the fiber with the middle deltoid. When the muscle action line it resolves into parallel and perpendicular components. In relation to the long axis of humerus, the parallel component directly superiorly by far the larger by the two components. That is, majority of force of contracting of the deltoid causes the humerus and humeral head to the translate superiorly. Only a small portion of force is applied perpendicularly. The rotator cuff and glenohumeral stabilization, the supraspinatus, infraspinatus, teres minor and the suprascapular muscle are composed. The rotator musculotendinous cuff, the action line of the four segment of the rotator cuff If any one of the three of the vector pull for infraspinatus, teres minor and subscapularis muscle is resolved into its components, it can be seen that the rotatory force not only tend to cause at least some rotation of the humerus given its orientation to the long axis of the bone. Although the infraspinatus, teres minor and subscapularis muscle of the rotator cuff are important GH joint, compressors equally critical to stabilizing function of these particular muscle in the inferior translatory pull of the muscle. The sum of the three negative translatory component, these three muscles of rotator cuff nearly offsets the superior translator force of the deltoid muscle. This is the diagram showing how it works. Although the supraspinatus muscle is a part of rotator cuff, the action line of the supraspinatus muscle, unlike the action line of the other three rotator cuff muscle, has a superior translatory component rather than the inferior component found in the other muscle of the cuff. Given its line of pull, the supraspinatus is not able to offset the upward dislocation action of the deltoid. The more superior location of the supraspinatus results in an action line that lies far further from the GH joint axis than the action line of the cuff muscle. Gravity acts as a stabilizing synergist of the supraspinatus by offspring the small upward translatory pull of the movement. The long head of the biceps brachii runs superiorly from the anterior shaft of the humerus through the bicipital groove between the greater and lesser tubercle to attach to the supraglenoid tubercle. The superior labrum, it enters the GH joint capsule through an opening between the supraspinatus and subscapularis muscle, where it penetrates the capsule but not the synovium. Within the bicipital groove, the biceps tendon is enveloped by the tendon sheath and by the transverse humeral ligament that runs between the greater or lesser tubercle. The long head of the biceps brachii, because of its position at the superior capsule and its connection of the structure of the rotator interval capsule, is sometimes considered the part of reinforcing cuff of the GH joint. The integrated function of shoulder complex. The shoulder complex acts as coordinated manner to provide smoothest and the greatest range of motion possible of the upper limb. Motion available to GH joint alone would not account the full range of elevation available to the humerus. Distribute the motion between the joint, permitting a large range of motion with less compromise of stability than would occur if the same range occur at one joint. Maintain the glenoid fossa in an optimal position in relation to the head of the humerus, increasing joint congruency. Permit muscle acting on the humerus to maintain good length tension relation while minimizing and preventing active insufficiency of GH muscles. So this is all about the shoulder complex. Thank you so much.